No questions? Okay. Well, you know what? Maybe still I will tell you over here. So someone could ask you on this. With the post-streptococcal, remember, so PSGN, also on the immunofluorescence, as I told you, they call it, if there is a immunofluorescence, they call it lumpy bumpy appearance. So it's like not continuous, okay? So that's the post-infectious glomerulonephritis. In case of good pastors, as I told you, the immunofluorescence is linear. So the whole basal membrane will be nicely shining like a one continuous line, okay? So remember this. So let's continue. So now in detail, we're going to talk about the proliferative glomerulonephritis, okay? So again, as we talked about, so post-streptococcal glomerulonephritis, as I told you, it's 2 to 3 weeks after, as you're having a sore throat. So you're having glomerulonephritis. You can have hypertension, typically children. So children, they can have an attack of hypertension, okay? They can have edema. And as I said, it's the type 3 hypersensitivity reaction. And the important thing over here is, in post-streptococcal, you don't have to do, in most cases, any diagnostic biopsy, because over here you can test them for something in blood. And what you will test them in blood, you take blood and you will look for ASLO or ASO, it's the same. So anti-streptolysin, which is the antibody you are producing against this enzyme that the streptococcus is releasing, and they're releasing also DNA. So you will look for antibodies against the DNAs. And if the typical child, has this in the blood, you can be pretty sure this is the self-limited, in a way, post-streptococcal glomerulonephritis, okay? Although few cases can end with or rapidly proliferating glomerulonephritis, okay? Then we got the IgA, so Berger, I'll put it again in red. So IgA nephropathy, that's IgA, really like glomerulonephritis. And Berger, remember why I'm telling you about biopsy. This is the case you always have to do biopsy, because that's the only way how to diagnose it. Although it's the most common in adults, you have to always do biopsy. And by the way, remember, either you're doing biopsy to diagnose the Berger's disease, that's the only way how you can know, because this patient has a fever, has a non-specific, let's say he's not feeling well, and now he has a hematuria, and you cannot find ASLO, anything else, then you have to do biopsy. But there are other diseases like SLE where you obviously know it's SLE because he has a, let's say, butterfly rash in the face. He has all kinds of antibodies. But the reason why you are doing it in this case, in SLE, is to know how severe is the SLE at this case. And basically, you need to do the biopsy to know if you should use already some cytostatics as cyclophosphamide or not. So for treatment, you need to do biopsy. But in all cases, watch out, biopsy can be very dangerous. You can bleed internally. So always think it wisely if to do biopsy. But in most of the cases, unfortunately, if we're talking about glomerulonephritis, and if it's not the post-streptococcal one, which is self-limit, whatever, you will at the end anyways do biopsy. Remember that, okay? So that's Berger's disease, and as I said, 1/2 or 1/3 will unfortunately end with end-stage renal disease, and it doesn't matter what you're going to do with them. If you give all kinds of corticoids and cyclophosphamide, at the end they will fail. So very dangerous one, very bad prognosis in half of the cases. And remember, typically over here happens the second day after viral infection. Okay, so there's infection of the upper respiratory tract or whatever, and suddenly, second day, hematuria. Okay. Well, and the third one, again, I'm repeating it, Henne-Schönlein, self-limited, only like 3%. It's the IgA vasculitis. It's okay. They have petechias, they have joint pains, and only 3% can't end with a nephrotic syndrome. And at the end, they can end with end-stage renal disease. Okay, so only a few of them. All of them are rapidly progressing or can turn into rapidly progressing. Okay, good. So these are a bit in more detail. So, and now we're getting to a big one, and this is vasculitis. All kinds of vasculitis. So these are systemic diseases, okay? You have inflamed vessels. So basically, the place of the problem could be anywhere. It could be lungs, in most of them. There's one which omits lungs. It could be GIT tract. It could be brain. It could be whatever you think. Eyes, typically. And basically, the problems like migrate within the body because it's vasculitis and you have vessels everywhere. And unfortunately, of course, we're talking about it in nephrology because they will cause, most of them, very serious glomerulonephritis. And those are the rapidly progressing glomerulonephritis, okay? So vasculitis, I will tell you 4 of them, okay? And remember, in most of the cases, they will be chronic. So it's going to turn into chronic kidney disease, but some of them, or not some of them, but some cases of these can really, really rapidly kill the kidneys. So it can end in acute kidney injury as well. So, and they all have a similar sign. So they all have GIT problems, okay? All of them. They can have a stroke. They can have a MI. They can have inflamed eyes, typically. Okay, so some uveitis, iritis, okay? And don't forget also joint pain, so joints inflamed, so arthritis. And don't forget they can have a peripheral nerve inflammation, nerve lesion in a way. So peripheral nerve inflammation, because the vessels are also, supplying the nerves, okay, over here. And it's the same for all of them, or majority is the same. So now what's different? Okay, so I'm going to name them first. So first, think of Wegener's, or in other words, the GPA, or in other words, granulomatosis with polyangiitis. This is a new term which is used nowadays. But Wegener's vasculitis, in a way, you can use it as well, of course. And what is typical with Wegener's? Well, it's a combination of glomerulonephritis, but typically over here you look for sinusitis or rhinitis, okay? So it's a upper respiratory tract infection. So sinusitis or rhinitis, and this can be pretty serious. So, and it's a chronic inflammation of the upper respiratory tract. So actually they have a deformed nose. It's called a saddle nose. So basically, if this is a nose, it's like deformed like that. Okay, so they have a saddle nose. That's very typical. It's like if they would be boxing, okay, it's flat. So that's a main sign. That's a very typical sign. Vaginal vasculitis, okay, or vaginal granulomatosis, okay. And remember, still, they have this nose, and what you can find in blood are some immunoglobulins, and these are C, which means C cytoplasmic c-ANCA. Okay, remember c-ANCA? So it's against the protease 3. And how does it look like? Well, it means that you have antibodies against your neutrophils, that's the ANCA. And if I will draw a neutrophil over here, and this is of course, this is the polysegmented nucleus, and this is the membrane. So you will see how the cytoplasm is shining. Okay, so those are the c-ANCA antibodies. And one more thing, if you do a biopsy and put the glomeruli over here under the microscope, you won't see any immunoglobulins in the glomeruli because there are only few immunoglobulins to see. It's very hard to see them. So that's why you call them also pauci-immune. So normally, yeah, if you look for the antibodies, that's okay. But if you check the glomerulus, you won't see obvious immunoglobulins or complexes in the glomeruli because there's only few of them, okay? So basically, pauci-immune is you don't see the Ig deposits on conventional microscope, okay? So that's vaginal vasculitis or granulomatosis. That's vaginal granulomatosis. And remember, typically there's an upper tract infection, very common one, and they have positive c-ANCAs. And they all cause, and very commonly do, rapidly progressing glomerulonephritis. Okay, so that's one of them, vaginals. And then another one is Churg-Strauss. Okay, so Churg-Strauss vasculitis, this one also can, of course, cause, like all of them, or at least the first 3 ones, they all can cause, this one can cause acute kidney injury as well, this one as well, and definitely it can turn into chronic kidney disease. And remember, Churg-Strauss is very much combined with asthma. Okay, so these people typically have asthma with combination with glomerulonephritis. Okay, and there could be lungs involved and kidneys involved. So lungs and kidneys. Okay, and in contrast to vaginals, remember, they have not c-ANCA, but most commonly they have p-ANCA. And p-ANCA means perinuclear. So they have perinuclear antibodies. So this is anti-myeloperoxidase. So it's the anti-myeloperoxidase, MPO. Okay? And MPO is in the perinucleum. So if you put a neutrophil in a microscope, you'll get antibodies that are aiming on the ANCA, p-ANCA. Or if they're aiming on the myeloperoxidase, I will write it here, myeloperoxidase. So if you take the blood, if you take the blood of the patient and you mark the antibodies, or use antibodies against this antibody, and you mark it with fluorescent agent, you will see not cytoplasm, but you will see exactly borders of the segmented nucleus. So that's p-ANCA, and that's typical for Churg-Strauss, okay, vasculitis. And maybe I should stress that this is small vessel. This is small vessel vasculitis, okay? And still, this is again pauci-immune, okay? And again, it can cause rapidly proliferating glomerulonephritis. And third one is polyarteritis, nodosa. And watch out. And remember, this one is very serious. And polyarteritis nodosa is specific because it skips lungs. So lungs are okay in this patient. Okay, he has problems all around like MI and strokes and whatever. And what is very dominant over here are GIT problems. So remember, you can do a angiography of the intestines, and if the mesenteric artery is like beads on a string or whatever, it's very likely polyarteritis nodosa. Okay. And remember, again, it's very unspecific. They can have anemia, they can have increased sedimentation, it's very an increased CRP, that's typical. They're having a fever and whatever. And suddenly, again, they can have a hematuria. Okay, so they're having glomerulonephritis. And what is special about polyarteritis nodosa, which is, again, third type of, or in some cases, it's definitely third type of hypersensitivity. So again, immunocomplexes, and I tell you which types. But remember, again, it can turn into acute as well. It can be really acute. But typically, please remember, this is connected. It's like 30% of diseases. We know it's connected with hepatitis B and also hepatitis C. Okay. So if the patient has hepatitis B and C, and now he has, like inflamed joints, now he has fever and whatever, and now he has also glomerulonephritis, it could be polyarteritis nodosa, very serious one. Okay, lungs are okay in this case. And remember, typically what you will find in these 30 cases only, and that's why I'm talking only in these 30 cases about type 3 hypersensitivity. That's mainly hepatitis B, but remember, C can do it also. And what makes the immunocomplexes over here in the case of hepatitis B, it's the surface antigen of the virus. So it's HBs antigen in combination with immunoglobulin that aims antibody. So this is the immunocomplex that actually is stored in the mesangium and makes the inflammation over there and causes the glomerulonephritis. And remember, if the polyarteritis nodosa is in connection with hepatitis B, the main thing you should do is try to fight the hepatitis B disease, okay? And remember, for diagnosis over here, the cool thing is you don't have to biopsy the kidneys to know the cause, because you can biopsy other sites. Like, for example, let's say you can you can do the angiography of the mesenteric artery, or you can biopsy a peripheral nerve. If the nerve is inflamed, you're going to find the complexes over there, okay? Yeah, but remember the connection with hepatitis B and C, that's typical, okay? So these are the three main ones, but still with if we talk about and this one is not pauci-immune, okay? The polyarteritis nodosa, you can pretty much see it over there. But still, I will mention one more, which is pauci-immune, and it's now mentioned a lot because in older days, it was like they were putting it under the polyarteritis nodosa. And one type was taken out and they made a new unit because there were small differences. And one of the differences is that in polyarteritis nodosa, you don't have any ANCAs. In most of the cases, no ANCAs, low percentage, okay? But in this one, and we'll call it microscopic polyangiitis. In this one, typically, it also causes glomerulonephritis and everything. It can really cause rapidly progressing glomerulonephritis, but you find, in many cases, you find p-ANCA and both and c-ANCA, okay? So remember, now they've taken these cases and they made it a new entity, and it's the microscopic polyangiitis, okay? And it's very like the Wegener's granulomatosis. It looks like GPA, granulomatosis with polyangiitis. But watch out, in this case, there are no granulomas present, okay? And moreover, you will find both of these antibodies, and it's also pauci-immune. So pauci-immune, so only few immunoglobulins in the serious glomerulonephritis that you're going to have with this microscopic polyangiitis. Okay, so it's sort of a new entity. Well, it's been for many years out, but if you find old books, they still sort of put it into polyarteritis nodosa. Okay, so rapidly progressing and pauci-immune, and you find both p-ANCA and c-ANCA in this case. Okay. Questions on this part? So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.